All of you, respected Professor Mehta, my mentor. Thank you so much for making it with such a short notice, sir. I know you're very busy, but we realize you always have the first priority to our department because you belong to our department. So we always feel that we have this right to call you whenever we can. And I would also like to invite personally all the faculty, particularly the international faculty who have made it. Professor Ido Strauss, who was there with us a few years back, is from Tel Aviv, Israel. He was almost about not to come because of the war, but somehow he could make it, and we are very grateful. And he's one of the leading functional and pain specialists, not only in Israel, but globally. And we look forward for really learning from him. He came here just a couple of years back, where he learned the technique of robotic thermocoagulative hemispherotomy done percutaneously, and they have implemented this in Tel Aviv, and we are really glad that this could be done there. Professor Milind, my dearest friend, I spent with him, I think, 2 weeks in Cleveland with him and his wife. It was a very nice experience. So he's really open-hearted, and he is always ever so enthusiastic to come and participate in academics and our conferences, and we really thank you for that. Girish, my dear friend, he was my batchmate in MCH, and I think I was very fortunate to have him because we had excellent relationships. We had a competitive relationship, but then we were closest of friends, and we would really help each other. So I'm so glad I've seen him. So currently he is one of the leading pain specialists, not only in UK, but among the world. And he's in charge of the entire subspecialty in Southampton. And anybody who wants to go and visit him, I'm sure he'll be very happy to have you there. And I believe this is only a beginning, Girish. I mean, let's go in for a very long inning. And I would, of course, like to thank my own faculty, Deepak and Ramesh, who have taken this initiative, because this has come as a result of a huge unmet need for not only the department, but also for this part of the country. So our department as such is already extremely busy. We are doing about 130 surgical cases a week. And we have about 9 operating ORs, and then we do about 30 to 40 gamma knives a week. And it's been rated, it's a legacy department started by Professor Tandon, Professor Banerjee, then Professor, like Deepak was saying, we had a pre-Professor Mehta era, post-Professor Mehta era, so then we had giants like him, and we sincerely hope that we can continue taking this forward. And we are very, very happy to say that our department has been rated number 1 in India consistently, number 2 in Asia, and number 11 globally. And if you look at its rankings, it's even higher than departments of neurosurgeries at Oxford, Cambridge, and even UCLA. So in terms of the work we do, in terms of publications we do. So the question is, when we are so busy, what is the need? Again, we are already struggling to get beds. There is always a need because the establishment of this institute was to demonstrate a model of healthcare and excellence. So we have over 40 residents, 45 residents, several fellows. So it's necessary that we demonstrate subspecializations in all the areas of neurosurgery. And for some reason, we could not develop pain so much, not because we lacked the patients, because we were always finding difficult to get some space for them to be done. But now we are expanding. So we have a 1,000-bedded cancer institute in Jhajjar, where again we would be establishing a department of neurosurgery. So being next to a cancer institute, we foresee that there is going to be a lot of space for these procedures to be done. And these are really, I think, very satisfying procedures because you are able to relieve the pain of these patients. And the very fact that there is an unmet need for this subspecialization is brought out by the fact that there are so many people attending. Our number of delegates attending this is increasing by the day. There is so much of interest for everybody to come and do this. So with this, I once again thank all of you for having made it here. And I will wish that this should continue every year. And you as faculty should come here every year, and we should develop long-term relationship. We should see how we can work together So I think in this world of increasing division, we should demonstrate cohesion to see how things can be done across the border. Thank you very much.
So we have been running a very active epilepsy surgery program since 1996, operated over 5,000 cases. And neuromodulation forms one of the primary verticals for epilepsy surgery, particularly VNS. The reason VNS forms a nice vertical is it's very easy to do. It's an extracranial surgery. Surgery will be over in 45 minutes. But its advantage itself is a disadvantage because then people can misuse it. So our program has been always very, very rigid in the sense that we would perform neuromodulation only when all the options are absolutely excluded, including in those MRI negative pathologies where we still explore the possibility of doing stereo electroencephalography, and then we do. So we have done about 100 VNSs. So our threshold for doing neuromodulation is not very low because we always explore the options of resective versus disconnective surgery. Now the disclaimer upfront is I don't have any experience of using VNS for pain. So it's a kind of a forced presentation because Deepak said that you should try to present something about the role of VNS. So I've gone through the literature. It's been helped by my fellow. I didn't have any time also for the past 1 or 2 days, but Aparajita, my fellow, has done a good job. She has combined some good slides. So upfront, you have to understand that doing VNS for epilepsy is like adding another drug. About 50% of the patients are going to have 50% improvement. And very rarely any patient is going to be seizure free. So, and that's one of the reason. And we have to also understand that the improvement of neuromodulation continues to happen over years. So, which means the second year improvement will be better than first year and so on. The third will be better than second. So, we have to wait patiently. Now, one of the caveats of VNS is that you have so many options while doing programming. So, that is the reason programming is very, very essential. And you have more than 8,000 combinations. So that's the reason, if we do a VNS, there could be a number of bottlenecks where you could fail the procedure. For instance, when you are putting it around the vagal nerve, if you strip it off, if you cauterize, the nerve is going to die. And you then put a wire around it, it's simply not going to stimulate it. So you have to very carefully preserve the sheath or the vagus nerve and then put it. Similarly, when you're doing your programming, if the neurologist is not clear about programming, you will end up a patient who doesn't have a good outcome. Now, I was looking at the timeline of utility of VNS. It has been in 2017, they have approved it for cluster headaches and chronic daily headaches. But this is an approval for non-invasive VNS, which means more like a cutaneous VNS or putting it on the neck. As far as I have seen in the study, I have not seen any studies where they have done an invasive VNS. I don't know if Girish or Milind have an experience of doing an invasive VNS for some kind of a chronic pain and all that. I'll be very interested to take their opinion, especially Girish's, to see what are the practice parameters in UK with regards to VNS. So the advantage of obviously vagal nerve is it's got the largest distribution, practically reaches to every organ in the body. So you have a potential outreach to every organ. So now the question is, if you stimulate this, is it going to have some effect on pain? Now this, I apologize for this busy slide, but this is fundamentally to show that we have a very rigid protocol for epilepsy surgery. And ultimately, when we are not able to form a reasonable hypothesis of surgical failure, only then we do neuromodulation, which should be the case for in every tertiary center. Otherwise, the threshold for misutilizing this is very, very low. I have seen VNSs being done for hippocampal sclerosis. So, some things are common for neuromodulation. So, if you do it, you have to understand that the onset will be slow. The improvement happens over a period of time. It continues to improve over a period of time. Don't expect any cure. So whenever you do VNS, there would be a significant reduction, but don't expect a cure. The placebo effect is quite significant because patient is paying a lot of money. There is a battery, he can feel the battery. He thinks it's like going to be like a pacemaker for cardiac. And of course, programming is very important. Now, we don't exactly know how VNS works. I have gone through a lot of literature and I have seen that, a lot of hypotheses, it has got an anti-inflammatory effect, it inhibits the mast cells, so many things have been written. But I think at this point, it would be suffice for us to understand that the VNS has got a very nice outreach to a lot of, I think almost the entire body has a supply by the VNS, and it acts primarily via the limbic system. So because the effect of outreach is there, it also alleviates mood. So it's been approved for depression. So that's the way it could be done. So if you look at various types of VNSs which are available, you could have a trans-cervical VNS, or you could have a transauricular or a percutaneous VNS. So you have to put some acupuncture needles and then you could stimulate the nerve. So these are the non-invasive VNSs which are available. Now, the reason it came into effect for pain, why the people started thinking is, they found that when it was operated for patients with epilepsy, they had a significant improvement in the mood. And many patients of epilepsy also had chronic pain. So that also improved with VNS. So that's what started for them to think that whether it could be. It's of course approved for depression. And more recently, they have used VNS for the right-sided failure, rheumatoid arthritis, sepsis, obesity. I think they mentioned everything except baldness. So I don't know if we can also include that. So over here, if you look this is a nice, it's a busy slide, but it's an important slide. So the black triangles are the FDA approved indications. So the traditional VNS is obviously approved for epilepsy, depression. It's also approved for stroke. But again, a number of it has also been done for general anxiety disorder, tinnitus, fibromyalgia, rheumatoid arthritis. The transcutaneous cervical VNS is approved for cluster headache and migraine, but it also has been performed for COVID-related inflammation, stroke, atrial fibrillation, post-traumatic stress disorder, opioid use disorder, and even painful chronic pancreatitis, which could be very painful and it's a very long-standing condition. The transcutaneous auricular VNS has not been approved, FDA approved for any of these indications, but it's a non-invasive. It comes mostly, it's done by a Chinese company. You can put it in the ear and you can stimulate it. And it's been approved for conditions like fibromyalgia, tinnitus, stroke, irritable bowel syndrome, post-operative inflammatory response, newborn feeding rehabilitation, opioid use disorder, depression, Prader-Willi syndrome, rheumatoid arthritis, erosive hand osteoarthritis, idiopathic nephrotic syndrome. So they have included practically everything. Now for primary headache, there have been a number of studies, and I found maybe one study where it was significant, but otherwise most of the other studies have not shown so much of improvement. And if you see this study, which is an Act 1 study, over here, particularly the episodic chronic headache or daily chronic headache, there has been a much better response with VNS as compared to where it was not done. Similarly, in the Presto study again, they have shown that there has been some more improvement of NVS as compared to sham trials. So the current guidelines, it can be used for acute or prophylactic treatment of headaches, which could be migraine, cluster, or daily chronic headache. But you have to fundamentally decide whether the headache is severe enough to merit a VNS, and again a non-invasive, and also medication overuse headache. The FDA approves it for acute treatment of again migraine, episodic cluster headaches, as well as for prevention of migraine and cluster headaches. Now, if you look at the approval of VNS for fibromyalgia, again there have been some studies which I could pull out, which more or less have shown that there is not much of improvement. So again, it's plus minus. It's also been used for backache. And surprisingly, when I went through some studies, the p-value seems to be significant. So again, it's very difficult to explain how backache could get relieved by VNS. But there you're opening a Pandora's box. But it remains to be seen. Maybe it works. I really don't know. So we'll have to look at it more carefully. So these are the current trials which are going on. So there are about 127 trials, and they're exploring it for various conditions, but mostly includes pain disorders and migraines. So again, I apologize for this busy slide, but the reason I have put here is that whenever you look at a study, most of the trials say that they are well tolerated. They don't mention about the efficacy. So we have to understand that the objective is not tolerance, because obviously, it's not much. Even if you do invasive VNS, it's a relatively simple procedure. So other off-label uses includes chronic widespread pain. So this we could have in some of the patients, chronic visceral pain like chronic pancreatitis, irritable bowel syndrome. And in one study, which was an RCT, they have shown up to 64% of improvement with irritable bowel syndrome. Diabetic neuropathy, again, in some cases of intractable diabetes, we get those patients, whatever medicine you give doesn't work. I don't know if VNS will work there. Chronic musculoskeletal pain. Now in India, we have a huge population of these patients coming. In Victoria, when I was there with Girish, we used to call it as HPD syndrome. Hatha Pava Dard syndrome. Practically every patient starts walking, they're saying, what is your problem? Oh, I have a pain here. And we don't actually investigate these patients. So it seems to be seen that what could be the problem with these patients. So I'll conclude this short talk saying that VNS definitely is established for epilepsy. But the threshold, I feel, should be not so low, it should be high. It's also approved for depression, and it's also approved for some kind of maybe migraine headaches or chronic headaches, which could be associated with the depression. But again, we'll have to take it with a pinch of salt. So I'm not too much convinced about pain right now. I think we need some really good studies. So I don't know if you've heard of Freeman. Freeman was a psychiatrist who took upon the responsibility of himself to perform a leucotomy for every person on this planet. So he learned it from the neurosurgeon, and then he would go on this lobotomobile, and then he would go on treating everybody. He would pass this hammer, this chisel through the eyebrow, and then he would do a leucotomy. And this was one of the reasons why it was overused. There were a lot of complications, and the US Parliament was also on the verge of actually abolishing psychiatric surgeries. Fortunately, they did not, because of which psychiatric surgery is still there. So I could show you a small video, because I believe most of you here are surgeons. So this was a patient where we had absolutely no localization, and we investigate all the cases quite a lot. We do magnetoencephalography, we do MELD imaging, we do ictal SPECT, PET, fusions, everything we do. So that's the incision. So first is to make a small pocket in the chest. Now it's a straightforward surgery, but remember, sometimes straightforward. Now this is in the neck, I'm sorry. So exposing the internal jugular vein. So I prefer using sharp dissection with scissors. I will advise you against using any kind of cautery here. So it's very important to identify the vagus nerve. Often you can end up seeing an ANSA on the surface and you think that is a vagus nerve. So you have to dissect the IJV as well as the carotid, and then you have to go into the space between them and then identify the vagus nerve. Often a vagus nerve has got its own sheath. So it's present in a very much more deeper area. Now over here you can say this is ANSA. So there are possibilities, people could confuse ANSA with vagus nerve, and you have to be careful about it. So you have to open up both the IJV as well as the carotid artery, go into the depth, and that is where you'll find the vagus nerve. And when you find it, do not strip off the vagus nerve. It's very important, because if you strip, it could easily get devascularized, and then the VNS is not going to be effective anymore. So that's the vagus nerve which has been exposed. So you could find this video on the YouTube. It's there it's been published in Neuralgia India. So we pass a sling around it, expose the vagus nerve from top to bottom, and then the electrode is brought here. So you have an anchor lead, the positive and the negative. So wrapping, this is the most technical part of the surgery. So it has to be done carefully so that it doesn't get twisted in a wrong manner. And then you have to leave a lot of redundancy so that you don't strip it off. So you have to provide at least 2 strain relief loops, and then finally it's connected and you do. So it's a relatively straightforward, but you have to remember certain bottlenecks where it could go wrong. So I will stop here. So thank you very much. So maybe some comments by Girish and Milind on what you think is the current role of VNS. Girish, take the mic so that they can also hear. Mic दे दीजिए.
Yeah, even DBS for pain is no longer funded in England. So we stopped doing DBS for pain in 2013 itself. VNS, again, even for depression, you have to go through lots of hoops. So VNS for pain, certainly a no-go.
Okay.
I don't think there's a good evidence for that, and it won't be funded.
Milind, you want to add something?
I mean, I told you this. The brain behind VNS is Warren Grill. Warren Grill is this absolutely brilliant neurophysiologist, neurologist, and he's turning into Peter Janetta. So his first thing worked so well, epilepsy, that he started. He said, "Why not depression?" And depression, it did not work, and I don't know why FDA approved it. And there was it was said that the chair of the FDA was the author in that publication. So there's huge conflict of interest. After that, they tried to do it in different things, but it doesn't work as well as epilepsy in anything else. And that is always the thing. Procedure that you designed for one thing works in that thing the best. And then just because you know how to do it, you try to apply it to different things. And it doesn't work. I mean, in his later days, Peter Janetta used to do microvascular decompression for diabetes. So those things are never going to work. I done ONS for fibromyalgia because ONS were approved in US for fibromyalgia. Help a little bit, not very much, but never a VNS for fibromyalgia.
Okay. Thank you.
Thank you, sir.